Welcome back to Takacs McGinnis Elder Care Law Hour. I'm your co-host Barbara McGinnis. In today's episode, we're going to be talking about dementias, the different types of dementias, what are your options for treatment after diagnosis.
And we're continuing our discussion with Dr. Kristen Assad, who is a neurologist at Tristar Centennial. Welcome back, Dr. Assad. Where we left off the break, you were talking about different symptoms and signs. What should families do when they see them?
I'd say at the earliest onset of symptoms, regardless of the symptoms, it's important to contact your medical provider as soon as possible. The reason for this is we were talking about potentially treatable, reversible causes of dementia. We want to look for those things early. If it's a simple infection, let's treat it. On the converse of that, if it does seem like dementia is what's going on, we want to recognize it, initiate therapy early, get patients set up with the right resources as early as possible.
So takeaway point there is really not to just attribute it to they're getting older.
That's exactly right.
Yeah.
And that may be what's going on. But it's better, I think, to let a medical professional make that decision in the event that it's not just normal signs of aging.
Different types of dementias, 5 types, kind of, is that?
More than 5 types.
Okay.
Definitely more than 5 types,
All
but
right.
probably the 5 most common types, at least in the United States, where we would see these cases. Above and beyond, Alzheimer's type dementia is the most prevalent form. Approximately 60 to 80% of the cases that we see in this area are Alzheimer's type dementia. But there's a lot of different variants that people are probably not aware of, not familiar with, and should be on the lookout for. Dementia with Lewy body is a very common subtype. It tends to occur a little earlier in life. Frontotemporal dementia is a different variant. Vascular dementia is incredibly prevalent in the South. We're part of the stroke belt. We see lots of vascular disease. So it's certainly a huge component of the dementia cases.
That's the old hardening of the arteries.
Exactly right. And Parkinson's disease, we are seeing, as our population is aging, higher incidence of Parkinson's disease, and those patients are at higher risk of developing dementia on down the line.
Well, not to mention mixed types, right?
Absolutely.
Just because you have one doesn't mean you don't have.
There's crossover. Patients that have Parkinson's disease may also have vascular disease, and their dementia syndrome might be more severe because of that combination.
Well, and this is interesting. So what are some of the different symptoms, one type of dementia versus the other? How do we know?
Great question.
Right, because remember, I think the average public thinks that you can't diagnose anything until you're dead. I mean, I think that seems to be the myth out there, that you have to have an autopsy.
And technically, to make a definitive pathologic diagnosis of any dementia subtype, it's done at autopsy.
Right.
But we know so much more about the clinical variants that we are able to, with fairly good confidence, make these diagnoses early and initiate the appropriate treatments. Of the subtypes, Alzheimer's is sort of the classic memory loss, confusion, gradual functional decline. It's progressive. This tends to be, still today, a disease of the elderly, considered 65 and older, which we don't really consider elderly. We don't want to consider elderly. But those are the mainstays of Alzheimer's type dementia. Dementia with Lewy body, however, extremely prevalent, probably 30 to 50% of cases that we see. Starts earlier. The symptoms tend to manifest in the mid-50s sometimes. It's early memory loss associated with sometimes severe visual hallucinations, Parkinsonism, and by that I mean the development of tremors, gait difficulties, rigid extremities. These patients also are exquisitely sensitive to a lot of medications that we might use. Those are sort of the mainstays of dementia with Lewy body.
Okay, but you didn't mention memory loss. Do they have some of that too?
Early memory loss. Early memory loss associated with the other symptoms.
Gotcha.
Another variant that's very interesting to see from a clinical perspective and can be very challenging to treat is frontotemporal dementia. It also has memory loss, but the prevailing feature with it is severe behavioral change. You may notice increased irritability, emotional lability, or even the opposite of that. Patients may lose empathy. They may become very apathetic. They might demonstrate compulsive or impulsive behaviors. These are the type of people that you might find embarrassing you in public. They may say things that they otherwise wouldn't have said before. So if you think your loved one is acting out, might be an alert that you need to seek medical attention. Vascular dementia is a little bit more challenging to characterize. That really depends on where the vascular disease is. Technically, if you have suffered a stroke that leaves you paralyzed on one side of the body, along with memory impairment, then that will be your clinical phenotype. But if you just have diffuse vascular disease, you may look like you have Alzheimer's type dementia. So that's a little bit more challenging to characterize clinically. The last most common variant, or of the 5 subtypes that I mentioned, is Parkinson's disease with dementia, and it is exactly as the name implies. The development of Parkinson's disease early on, and then the eventual development of a dementia syndrome on top of it, memory loss, but the Parkinson's features are what develop first. Tremors, rigidity, difficulties with gait, changes with bowel and bladder habits, difficulties maintaining blood pressure, patients might fall. Those are probably the most common symptoms of the subtypes.
Interesting.
Treatments for these different types.
Treatment options. In my opinion, the mainstay of therapy for any subtype of dementia should be the non-pharmacologic treatment, the supportive care, making sure that your loved ones' environments are as safe as they can possibly be for them, removing potentially dangerous scenarios, removing car keys if that's indicated, trying to maintain adequate nutrition, hydration, maintaining a good exercise regimen, 30 minutes of exercise a day.
Stuff you can have control over, right?
Things that you can do something about.
Right.
The pharmacologic treatment includes probably the 2 biggest drug categories are the cholinesterase inhibitors. Those include drugs like donepezil, ribostigmine, galantamine. Donepezil is the one that's been FDA approved for the longest.
That's the one that we know is Aricept, right?
That's Aricept.
Okay.
Exactly right. Those are indicated in early dementia for most of the dementia subtypes. So it's, if there's no contraindication, patients should be started on those drugs earlier.
And those do what?
Those
slow down, improve memory? What do they do?
They don't slow down the disease process necessarily. They may decrease long-term morbidity and mortality associated with dementia. They may allow someone to maintain their current level of function for a longer period of time. They don't reverse the effects of the pathology, but they might keep you functional for a little bit longer. The second class of drug is the only FDA approved one is memantine, or Namenda. It's an NMDA receptor antagonist. That's a specific drug type. It actually may have some benefit of reversing the pathologic features of dementia, but it's only approved for moderate to severe dementia. It's usually an adjunctive therapy that you add on top of.
Okay, so it's taken with the Aricept, right?
Usually.
Gotcha.
Usually, yeah. Sometimes it's taken as a monotherapy if patients don't tolerate the first subclass of drugs.
So what about particular tests? How do you determine? It sounds like you do the screening thing to figure out what slot they're in, right?
And that can even be very difficult, particularly early on. General battery of tests that a neurologist would use to make the diagnosis of dementia include looking at their B12 level, looking at their thyroid function, doing a blood count, usually doing some sort of radiographic image, a CAT scan or an MRI. those are primarily tools that we use to rule out something else.
Mm-hmm.
Then we use a battery of different cognitive assessments to try to determine the degree of dementia that we're seeing. There's a couple of tests that we use in the clinical setting. One's called the Mini Mental Status Exam, the MMSE. Mm-hmm. Another tool that we use is the MoCA test, the Montreal Cognitive Assessment Test, mm-hmm. and these can kind of help primarily determine the severity of illness that we're seeing. If you want to further subclassify the dementia subtype, then we often get our neuropsychologists involved to do actual neuropsychological testing, which is a far more intensive battery of tests that can lead to a little bit.
And I think we have one here, right?
I think we do, which is
mm-hmm.
excellent. But,
mm-hmm.
yeah, there's no real test though that tells you what exactly is going on. There are newer imaging modalities that are available to us today, PET scans and DAT scans, that can look at the metabolic activity in the brain mm-hmm. rather than just the structure. They can help facilitate the clinician in making the diagnosis, but ultimately the most revealing and the most useful tool is the clinical examination over a longitudinal time period.
Long period of time. So we've just got a few seconds left.
Sure.
How do we get to see you? Referral from a PCP, primary care physician?
Really depends on your insurance. Most insurance today and most Medicare subtypes don't require any sort of referral. Patients could call a neurologist's office directly and get an appointment.
Gotcha.
The easiest thing to do would be to probably check with your insurance provider or to check with your PCP and see if a referral is necessary.
Great.
All right, we've got your contact information. We're going to put it up on the screen.
Perfect.
And we want to thank you for being here with us today.
Thank you so much.
Dr. Kristen Assad.
Thank you.
So when we come back from break, we're going to be talking with a neuropsychiatrist. Come back soon.